I'm Tim Dalglish, and I've got the pleasure of welcoming Glyn to, I think this is the second virtual psychiatry seminar, so everything should be perfectly smooth now, Glyn. So it's a great pleasure to have you here virtually. I don't think Glyn needs too much of an introduction. He's Professor of Psychiatric Epidemiology at UCL, where he also did his medical studies, and obviously one of the giants of the field of UK and worldwide psychiatric epidemiology, particularly interested in causal factors of depression and psychosis, using longitudinal cohorts and big data, but also fantastic work using randomized controlled trial designs to look at treatment of depression, particularly in primary care, some of the most influential trials in that area. Perhaps less known is that Glyn is a tenor saxophonist and a member of the, I think, Oxytronics, I think they're called, who, I think this is embarrassing, coming up in a few years to their 50th anniversary as a band, formed in Oxford, have their own Wikipedia page. Dixieland Jazz, I think I would summarize it as.
Yeah, so
we should have asked you to play a bit as well, Glyn, as a kind of warm-up. But
yeah, no, I've got my saxophone outside, so any requests, any tunes. In fact, I do have the challenge of trying to record something to create a Zoom band thing, which apparently is amazingly complicated and involves everyone doing their own tape, and then it's combined in Zoom. But anyway,
excellent.
That's this weekend's task.
Okay, well, without further ado, I'm going to hand over to Glyn.
Okay, well, thanks very much for inviting me. And I'm going to talk about minimal clinically important differences, MCID for short. And this is part of a program of work. And I think you've already heard about the results from the randomized trial here called PANDA from Glyn Lewis, who is no relation. And this work was sort of part of that program. And I will, and you'll see why in a couple of minutes. But the background, which you know, is that antidepressants are very, very, very widely prescribed. I think we're up to over 70 million prescriptions in England alone at the moment, and it's going up year on year. It's one of the most commonly prescribed medications in high-income countries, and this increase has occurred in all high-income countries. And Andrea Cipriani did this fantastic review of all the evidence, which included, I think, over 100,000 patients, and found that indeed all the antidepressants that he looked at were effective compared with placebo. But there is a big but about this evidence. When it was presented, saying, there is, we don't need to worry again about the question about antidepressant effectiveness, and clearly that is, one way of looking at this. But there are some big limitations of this data. That they were conducted many decades ago. Andrea's own rating said that 82% were either at moderate or high risk of bias. And that the large, more recent trials have shown smaller effect sizes. But perhaps most importantly, these were trials done by the pharmaceutical industry just to get things across the regulatory threshold. And they were done in secondary care with eligibility criteria like diagnosis and severity. But in fact, that's not the way that antidepressants are used in, these days. They're prescribed in primary care. The decision is often a judgment. People or the GPs aren't using diagnostic criteria or severity thresholds. Of course, the milder depressive symptoms are still causing considerable distress and impairment. And indeed, there is work which illustrates, here's a paper by somebody involved in PANDA, Tony Kendrick and colleagues. And you can see that, you can get, people are being prescribed antidepressant at these very, very low scores, well below 10 on the PHQ, which is the normal threshold. And of course, even those above 10, many aren't actually reaching diagnostic thresholds for depression. Why is this important? Because there's this idea which came from this or started to come from this infamous paper by Irving Kirsch, which is that the difference between drug and placebo increases as the depression severity increases. And you may well be familiar with this graph, but down the bottom, you've got the severity of depression at the start of the trials at the bottom, and you've got the amount of improvement, and you can see that the drug and placebo lines actually separate to a greater extent at the higher severities. And that was an aggregate meta-analysis. There have been individual patient data analysis. The first one, which was quite small, only about 6 studies, seemed to support that idea. In fact, the subsequent individual patient data meta-analyses have not supported this idea. But when we started PANDA, that was the background. And so the PANDA RCT, just to remind you, was to investigate the severity and duration of depressive symptoms associated with a clinically important response. And the primary analysis looked overall at the clinical effectiveness. We know the results of those. But the hypothesis was something like this when we set out, that as a bit like that graph of Irving Kirsch, we had this increase in the difference between placebo and antidepressant as depression severity went up. And what I'm going to talk about really is this bit. Sorry, let me just use my pointer. Sort of this bit here, because the idea at the beginning was really to try to personalize the treatment in a way that you could say to somebody, well, if you're likely to be above this point where the minimal clinically important difference corresponds with the treatment effect, then you should be on antidepressant. But if you're below that line, then clearly you're not going to get a benefit, at least on average. And I suppose this comes back really to how we tend to talk about trials. We usually say, is it effective or not? And clearly that isn't really the right question to ask. It's about how much benefit will people receive. People have to make a judgment about whether they want to take a medication or not. Doctors have to make that recommendation. And the costs and benefits of that depend upon how much benefit people receive. And so we want to be able to say, ideally, both on average, you're going to benefit, and in some utopian future, to say to an individual, you'll benefit. And at the moment, we clearly can't do that. Well, I wanted to show this again because, this big meta-analysis of Andrea Cipriani's had over 100,000 patients. So it's not really surprising that all these treatment effects were statistically significant. And I suppose it returns to the same point, how do we know whether these differences are of clinical benefit, and therefore that we should recommend antidepressants? As we all know, there's a big difference between clinical significance and statistical significance. So one way in which people have sort of approached this is really to say, well, let's just look at categories and outcome, whether you recovered or not, and to sort of eyeball the percentages. And so, for example, let's say in usual care, 30% are going to recover. Do we think it's clinically important if the treatment leads to a 35% recovery, or a 40% or a 45%? And in general, when I talk to, do teaching or something, people tend to settle at somewhere around the 10% mark, possibly slightly less. And this is just a sort of an idea, is it worth taking an antidepressant if that's the difference in outcome? And indeed, when I've done power calculations in the past, it's the physical activity trial, that's the approach we take. Here we said a 13% difference gives you a sample size of 300. So it's still quite a big trial overall when you take into attrition into account. But it is one approach to looking at just, how important effects are. But it's quite subjective, and I'm not aware of any kind of more formal work to decide what is the value of those kind of percentage changes. if we apply that kind of approach towards the PANDA results, then we ask this global rating question there, which I'm very proud of, because I'm not aware that anyone has previously asked patients whether they feel better. And I'll come back to that in a minute. But this basically says, do you feel better compared to the start of the trial? And you can see the percentages along the top line here. So by 6 weeks, 59% on surgery said they felt better against 46%. That is, as it happens, a 13% difference, a bit more at 12 weeks. So on the face of it, you could say, is that an important difference or not? Probably is. The other method which tends to be used quite often is looking at standardized mean differences. So as you know, that's just dividing the mean difference in your trial by the standard deviation. And it is quite often used as a way of saying, well, is that a big effect or a small effect? And it's used to combine treatment effects on different scales. It's a standard thing that is done within meta-analyses quite often in order to summarize results across different scales. But there is a big problem with this, is where do you get your standard deviation value? In fact, Sander Greenland has said it's like dividing your treatment effect by a random number, because there are so many ways you can source that standard deviation. So, this is, a normal distribution, just reminding where these standard deviation estimates come from. Of course, many distributions are not normal. At the beginning of trials, quite often people have to meet a threshold criterion to get into the study. So you end up with, for example, people below some point being excluded from the start of the study, and yet people will use this truncated distribution in order to estimate standard deviations. And there's nothing constant about a standard deviation. Standard deviations are there to describe the variability of the population. Populations will vary in their variability. Why should we take a standard deviation from some particular trial and then try to generalize it to other populations by using this method? So even though this SMD type method is widely used, there are real issues, I think, about this business of dividing by a number which, on the face of it, should not be constant between different populations and should be impossible to generalize from. So that's where this sort of MCID idea comes in, the minimal clinically important difference. So it's usually defined as the smallest change in a treatment outcome that a patient would identify as important. It's clearly important that determining the statistical power of a study, when you're planning a study, you want to do studies to make sure that you can detect that kind of difference. It's very important for interpreting the results of trials as well. And of course, it deals with this issue about things being statistically significant, but not clinically significant. So there are various methods of doing that. And I've sort of already dealt with these two at the top about just sort of, eyeballing percentages or using SMDs. And the other approaches, well, first of all, the NICE depression guidelines actually came up with a consensus rating, which was chaired by David Goldberg, who, as you know, is a very consensual person. And they came up with 3 Hamilton points. There was no empirical evidence behind that. It was, a committee room came up with a number 3. There's also a method, tends to be called reliable change index, which is primarily based upon the standard deviations of the measurement error of the scales. So it's really saying these scales have a sufficient reliability. It can, from a psychometric point of view, it cannot pick up a difference below this point. But none actually involve the patient perspective at all. And there is an anchor method, so-called, which has been used actually in rheumatology and in some health economic studies. And we chose to take this approach. So that the anchor is a global rating of change. So as I mentioned earlier, we just ask people, do you feel better? And if you're in a trial or any sort of longitudinal study, you can then see what kind of changes have occurred in the people who felt better. And so you get an idea of, that minimal difference that at least is detectable, if not perhaps valued as important. Now, and we've looked at the reliability of this, and it's actually quite good. When we ask, we put the same question in the same assessment, separated by some other assessments, and the kappa was about 0.8 and the intra-class correlation 0.95. So patients are able to make this judgment reliably. We've also done some qualitative studies as part of the program, and in general, people are quite like this question in comparison with the kind of self-administered scales like the PH3-9 that we tend to use. So they say that it allows them to sum up in a global way how they are feeling. It allows people to include comorbidity when they're rating improvement. And usually when you do qualitative work on people completing these self-administered scales, they find them very limiting in the sense that they don't quite catch what their problems are or their severity and so on. But on the other hand, that some people did say it is difficult to recall how they were feeling 2 weeks previously. And clearly this is a sort of retrospective judgment over the last 2 weeks. We're all skeptical about the reliability of that judgment being made. And indeed the qualitative studies pointed that out, or the patients pointed out to us. So we took this anchor type approach with some existing data, trial data we had sort of lying around where we'd asked this question. And the 3 studies we chose as these GenPod, which is an antidepressant study between citalopram and reboxetine. TREAD was a physical activity study, and then COBALT was in a treatment-resistant population, CBT versus usual care. So that this is a much more chronic. If you look at the proportion who had depression lasting more than 2 years, you can see a much higher proportion in the treatment-resistant group, as one would expect, which I've highlighted there. So if you take time 1 to time 2, these are the kind of results you get. And you can see the sort of global rating here, much better to much worse. And these are the mean changes observed between time. So these questions were asked at time 2, if you like, in the follow-up, which was in the order of about 6 weeks of these studies. And so you subtracted, if you like, their Beck depression inventory score from baseline from the follow-up at 6 weeks. And so you can see that for the much better people, they showed a much bigger drop than the much worse people, as you would have hoped. But you will notice that people who said they felt the same also showed quite a big drop in all 3 studies. So we thought possibly the likely explanation for this is regression to the mean. And just to sort of explain what that means, I've got this kind of curve of somebody who is varying around a mean. So the mean is this sort of grey line, and their actual score is going up and down over time. And that can be either due to measurement error or to natural changes in symptoms, irrespective of measurement error. But for most studies, and including the studies we've included here, people have to meet a sort of severity threshold to get in. So you're much more likely to get into a study when you're feeling like this. But when you're followed up, on average, you're going to feel down, you're going to report down here. In fact, Jeffrey Rose, the epidemiologist, called regression to the mean the physician's friend. It means that our patients do tend to get better, whatever we do. And I think what I'm proposing really is that these sort of changes we're seeing in these studies are about sort of 6 points or maybe slightly less in cobalt, are a reflection of the likely size of regression to the mean when we look at randomized controlled trials. This is possibly important for the way that IAPT look at outcomes, because clearly they don't have a placebo or a sort of non-treatment group, and they look at scores which are subtracted from baseline. And so these calculations of what they refer to as improvement actually refer to things which aren't probably improvement. They include the regression to the mean effect. So in these randomized trials, the first time point is a bit useless for trying to look at minimal clinical differences because of this effect. So we concentrated, if you like, on time period 2. So that's asking people at the third time point, how much better are they? And then comparing that with the scores or the change between time 2 and time 3. And we can see the same pattern here of, a greater improvement when people say better, and a deterioration when people say worse. And the kind of same scores are now, well, possibly not in this study, sort of closer at least to 0. Sorry. So, on the face of it, so what we're saying is if you feel better, you are getting an improvement of, about 4 or 5, slightly larger in the cobalt study, points. And so this is, if you like, an estimate of the MCID. So you might say job done, we all go home and it's actually 5 points on average or something. But unfortunately, life is more complicated than that. And if you look at the blue lines on these graphs, they are the mean change of score in the BDI according to where you start, the baseline BDI at time 2. And you can see that the difference is getting larger as you have a more severe depression. So, we call this baseline dependency, which means that really if you start at a higher point on the depression scale, you need a bigger drop to feel better. So we thought, well, what about plotting it as a percentage reduction? And that did lead to a better fit. And you can see that these lines are much straighter now, if you like, that, irrespective of the severity of baseline, there seem, the percentage reduction model seems to fit slightly better. However, if you think about this, these are the average change of scores for people feeling better, but you could take an approach where you look, almost like signal detection theory, what sort of change do people require in order to feel better? And that's a kind of receiver operating characteristic curve analysis, a ROC analysis. And here, using the cut points, we can see that it was about 1 or 2 points in absolute change, and the percentage change was slightly low, in the order of about 17 or 18 points. 17 or 18 percentage points, sorry. You can also notice that in the cobalt study with these sort of more chronic long-term patients, they seem to report feeling better with a much larger percentage change. And indeed, our qualitative work suggested that people with very long-term problems were quite cautious about saying they're better because they sort of had periods of feeling a bit better in the past and it had all gone wrong, if you see what I mean. So they tend to be a bit more cautious in actually reporting an improvement. And in various other analyses, we could demonstrate that actually the cobalt patients were different from the more acute patients in GEMBOD and TREAD. I can see there are a few questions popped up. I don't know whether, perhaps if I just So in summary, this part of the work suggested that looking at percentage improvement was probably a better way of looking at it than just an absolute change, and that the sort of just noticeable MCID, if you like, was probably in the order of 17-ish%. And the average change in terms of percent was much higher for the average people who reported feeling better, and Cobalt we needed a bigger change to report improvement for them. I don't know if we should stop and just take some of these questions. Tim, what do you want me to do?
Entirely up to you, whichever there's a couple of questions that have come up.
Yeah.
Now that's fine.
Yeah, sure. So, Tamsin, you said, how do you optimize a global anchor question? We did a bit of qualitative work on this. So we recommend this sort of 5-item thing where you can say, I am slightly better or definitely better, that kind of option. And that seemed to be more preferred when we looked at it, because some people found just having one option was quite restrictive. And you mentioned about the benefits of medication and the long-term side effects. I think that is not, this MCID approach is only about the benefit side of it. It's not the cost side. And I think that is an issue, which people haven't, obviously it does need to be taken into account, but I'm not sure of people who have tried to do that in a systematic way. And there's also the kind of hassle of taking a tablet kind of cost, if you like. People don't like being on tablets, even if they don't have side effects. And that is also something which needs to be taken into account. But perhaps that is such an individual thing that it's, as long as you can say these are the likely benefits you're going to get and agree with the adverse effects, people can make that decision, at least with more information. I don't know if that answers those questions, or if you've got any supplementaries. So these trial results were in people who sort of got over this threshold. They had diagnosis of depression. And as I said, in PANDA, we needed to extend this work to much milder levels of depression, because that was the population we were interested in including. And so we did this in a cohort, and these are just some graphs to show the change right down to sort of quite low scores on the Beck, and we also looked at the PHQ and the GAD. And the following table really summarizes our results here. So we kind of divided them into sort of 3 bands of severity. So if you look at the top there, we had 3 bands, either PHQ around 4, around 8, or around 12, and corresponding on the other questionnaires. And we've got the absolute scores in the next one, and then the percentage scores. And what you can see, in fact, in all these questionnaires is that when people get down to these very low scores, the percentage you need to report, or the percentage change you need to feel better, jumps up considerably. And indeed, you might have noticed this from those graphs with the blue lines I showed earlier, that was also seemed to be happening in the RCT studies we did. And if you think about it, if you're beginning on 4, even a 1-point change is 25% of your score. And it seems very intuitive that people are finding it very, very difficult indeed to decide if they have got better or not. And in fact, this, the modelling that my colleague Daphne Canali did show this sort of variance at these low levels was just becoming very, very large in the way that people trying to estimate whether they're better or not. So even though this kind of percentage rule might apply at the higher levels, it doesn't seem to do so well when you get to these very low thresholds. and the change you need to feel better becomes much larger. So sort of in conclusion, I think we can say that MCID does vary according to baseline severity. The way you start on the depression scale, the change you need to report improvement does vary. That this a kind of headline 20% reduction might be a good guide, at least for the higher ranges of severity, but at lower severity, the MCID does increase. And as you might imagine, at lower severity, it becomes more difficult for patients to detect improvement. But there are some limitations, obviously, of this work. The first one is that we are using this global rating as a gold standard, but it is a retrospective opinion about whether changes occurred. So there's obviously potential for bias there. We're not asking whether this change is important. If you like, we haven't got the I in the MCID. But the reverse is that if somebody can't detect a change, then I think is unlikely to be important. But perhaps most importantly, at present, our estimates are very inaccurate. And when we take slightly different analytical approaches, we get different answers. And finally, these are average MCIDs. Ideally, we'd like, we've already had evidence like that result for COBALT, but it might vary between different individuals. And other evidence also suggests that various clinical and personal characteristics might influence whether people feel better or not. So I wanted to sort of go back to the PANDA trial to see how we can, given this work, which is, sadly not very clear cut, I think it's fair to say, how it can be applied. And you remember this was the sort of hypothesis we started with, that we have this MCID, which, in hypothesis terms was an absolute value. Now we know it probably isn't. And also that the placebo antidepressant difference actually increased with severity. And I already mentioned that a lot of the, all the big IPD meta-analysis of this question haven't provided convincing evidence for that. And indeed, in the PANDA trial, we found absolutely no sign at all when we stratified by lots of different measures of severity. If you look at the bottom of this table, you've got whether people have got depression or not, the treatment effect, and that's in percentage terms, so that means a 5% drop, was absolutely identical, whether you had a diagnosis of depression or not. So if you like, our hypothesis was convincingly disproved on both counts. And probably this is a more realistic view of what might be going on. At least that's what we would conclude at this point. In the sense that the treatment effect between placebo and antidepressant is pretty much constant across the whole range of severity. And indeed, that kind of makes sense with some of Hap Palmer's and others' work, showing that antidepressants do affect things like emotion processing, which might be sort of unconscious or automatic, but which are still differences in the way people are performing when they're on antidepressants compared to they're off. And that's, of course, in people without any symptoms at all. So, maybe antidepressants are being equally effective right across the whole range of severity, but at low severities, people can't really tell the difference about whether they feel better or not. So if we wanted to incorporate this kind of approach into clinical decision-making, actually just one point to make here, that in principle, if we had good enough estimates of both the treatment effect and the MCID, you could still envision a sort of threshold above which people ought to be treated. So I think even given this sort of change in picture which we see, one could in principle still come up with a point above which people would on average benefit. So if we wanted to take this approach and actually incorporate it in clinical decision making, then there are a few things which we need. First of all, we need to have a link between trial evidence and clinical practice. And I think that can only happen if we use the same measures in both. A lot of the pharmaceutical evidence is used the Hamilton scale. That is not used in clinical practice. It never is used. So we need to be, have an alignment between clinical measures and research measures. We need better knowledge of what this MCID is and how it varies with severity. So we can, in principle, give both average and individualized predictions based upon that. The other important point, though, is that we need to be able to predict the future. We need to be able to predict severity at follow-up from these measures before the medication is provided, because that's the decision we're being asked to make. So if we go back to this graph here, what's important here is that this is depression symptom score at follow-up. So we have to use a counterfactual argument, which is a long word and a very simple idea, which is really we have to say, well, if you were on a placebo in 6 weeks' time, I can predict you'd be at sort of this point. Whereas if you're on antidepressant, I can predict it would be at this point. So in order to apply these MCIDs, you need to be able to do this kind of prediction into the future. And we need to be able to predict severity at follow-up from medications before the medication is provided. So I suppose my final conclusion is that, that trying to translate research result into clinical guidelines for antidepressants is not as straightforward. It's quite a difficult process. And we do need to know more about quite a lot of things. We need to know more about patients' own experiences of improvement. We need better information on predicting the severity of symptoms in the future. And I know this is a cliche, but I think further research is needed. So thank you very much. And I'd just like to acknowledge my very excellent collaborators who've helped with this work. So back to you, Tim.
Thank you very much, Glyn. That was fantastic. I'm going to unmute everyone so you can have a virtual round of applause, or a real round of applause virtually.
Thank you. Okay.
So we have some questions that have accumulated. So David had a question. So if you want to speak up, David.
Hi, David.
Hi, sorry. Thank you, Glyn. Great talk. I'm just wondering, you probably have thought the same yourself, but we're basing your MCID on an ordinal scale. And I think what your data shows is that actually, 1 to 2 isn't the same as 9 to 10.
Yeah.
And so is it valid to try and do what you're trying to do?
Well, I expect, one thing which we haven't done, which I sort of speculate about, is whether we can use these patient ratings to actually almost sort of calibrate the scales we're using. So as you say, what it looks like is that 5 points at the bottom of the scale is different from 5 points at the top. I think it's valid to use this approach, but I think it does have implications for how we both think of and analyze the data. This was one of the motivations for when we analyzed PANDA. We decided to use a percentage change in symptoms as our outcome, for example, which is very easy to do. All you do is log the outcome, and then the regression coefficients, when they're exponentiated, come out with a ratio. So it's a very simple thing that, it doesn't require complicated stats or anything. But perhaps that is then reflecting more closely the way that the scale is performing in the people completing it. But I'm not sure it's a criticism of this approach. It's more a criticism or a fact that seems to have emerged about the scales.
Yes, no, sorry, it wasn't a criticism of the approach. I guess I find it hard with using inferential statistics on ordinal scales anyway. I find it a hard concept for me. So thank you, though.
And Isabel, did you have a question?
Hi. Well, really, just as it said, just whether there was a change in response to treatment over time in terms of whether resistance to treatment had an effect.
Yes, well, during the PANDA trial, we only followed up to 12 weeks, which I regret now, because any antidepressant effects seem to emerge quite late on the 12-week follow-up, and it would have been really valuable actually to have carried on at least for another 4 weeks, possibly 8, to see if that became more convincing. So I'm not quite sure what your question is asking, I suppose, in that sense. That
well, I suppose over time, the short period of time, it makes it very hard to see. But in certain cases, some people need ever increasing doses of treatment for there to be a benefit. So I wondered if that influenced the result, or whether some patients experienced that.
Yes, so well, in the PANDA trial, you could get up to 3 tablets of 50 milligrams. Obviously, it was blinded, so they might take placebo. But we told everyone to go up to 100 milligrams, if you like. And then if they weren't getting better with the permission of the PI, they could go up to 3 tablets. And in the order of about 10 or 20% of people went up to 3 tablets. So we weren't right on the top of obviously the maximum sertraline is 200. Certainly those are the doses usually used, and the psychopharmacologists will tell me that the serotonin reuptake molecules are sufficiently inhibited at that sort of level.
Okay, thank you.
Muzaffar, did you have a question?
Yes, I did. I think there's a bit of discussion about the higher doses of depression, so antidepressants in depression, and I know that the literature is really not very clear on that. So if we ask the same question for the MCID, so have you noted any effects of higher doses of antidepressants on MCID, as in how people feel subjectively?
No, that's a good point. But I suppose as you say, the evidence is a bit mixed really about whether these higher doses make very much difference. And often the differences seem very small. And I suppose what the MCID approach is saying, well, maybe, is that small difference really a clinically important difference or not? So I suppose in principle, it could help with those sort of judgments. But I suppose it's more of an emphasis on, as I said sort of earlier on in the talk, it's, we shouldn't just think about things working or not. It's about how well they work, and it's in that context whether higher doses are more effective. It's more, are they effective enough for people to make a difference, given some of the side effects, the increased burden of side effects people are experiencing. And of course, these are averages all the time. It's an average MCID, and people are unique. And there are obviously lots of other reasons why higher doses in some individuals, because of the metabolism of drugs or whatever, they might need a higher dose than others.
Thank you.
And I'm sorry, I don't know the first name. Jay Rubenstein. I guess it's not David, but do you want to ask?
Judy, I think. Yeah.
Hi, Glyn. It's David's wife, Judy Eaton.
Oh, hi there.
Sorry, Judy. I wasn't sure. I was close then.
I had 2 questions. The one was you suggested that we should be using. I wondered what scales we should be using in clinical practice that would more correlate with research practice.
Yeah, well, I always think these scales are equally bad as each other, and probably I think, well, PHQ-9 is being used more and more. There's no copyright. There's always this threat from things like Beck, who will come chase you after some fees for using the copyright, and it's quite short. And it seems to perform as well as any of the other ones, in our experience anyway. And we have done some psychometric work trying to look at the treatment effects onto these different measures, and the PHQ-9 comes out as being quite good on those, actually. And I think there's sometimes advantages of shorter scales because patients get tired and fed up, and I think most people would feel depressed after completing the Beck Depression Inventory, even if they didn't start being depressed. So these shorter scales perhaps are advantageous for that. But
yeah, well, that's great to hear, because it's being used a lot, PHQ-9. And my other question was really looking at sort of, should we be looking more at personality factors to see why patients respond positively as to whether they've improved? I mean, it just seems so obvious as a clinician that is, some people are just half empty kind of people.
Yes, no, exactly. Well, I think that is the weakness of this global rating, is that you are asking this opinion about how things have been in the last 2 weeks. And obviously, sometimes our patients aren't necessarily the best judge of that, it seems.
Yeah.
But on the other hand, asking the patients, that's what we're trying to do, isn't it? Get people better. I think I mentioned this qualitative work we did on, and it's quite interesting because one of the studies we did was we interviewed people, or a colleague, Alice Malpass, when I was in Bristol, interviewed people as they were filling in the questionnaires, saying, why did you answer that question that way? And, people are making quite complicated judgments, including people who say, well, I didn't want to answer too severely because I thought that would make me feel I was worse. It was almost like kind of rating your symptoms less was going to make you feel better. And of course, the reverse happens as well sometimes, that people want to appear iller to get more help from the service. So people are making these quite complicated judgments when they're completing the scales. So, and clearly those sort of personality factors are going to affect that. And this cobalt group, this treatment-resistant group, that was, they did say, I might feel a bit better, but I wouldn't say I felt better, because I've had depression for years and years and years, and I've had periods when my mood's gone up and down and has gone back up, and it's not really feeling better. It's just a blip. So, it is. That I'm sure that is important, and I think if we want to provide this guidance, we probably need to have a better understanding of it. I agree.
Thanks.
Andrew, I think you had a question.
Well, I was sort of echoing David's question about the ordinal data, but just sort of pulling on that thread of, I wondered if you'd looked at the individual items within the questionnaire, or even considered item response theory approaches to this.
Yeah, no, that's, it's good. Well, we haven't. It's an interesting idea, and I agree it would be, would potentially be worth doing. In fact, we have, with some colleagues, Steve Pilling and Josh Button in UCL, we've managed to get it into the IAPT database locally, this question, the global rating question. So what I think we do need is a lot of data to sort of understand this, actually, especially when we're trying to look at whether sort of particular characteristics of patients or particular parts of the questionnaire are more or less related to these judgments that patients are making. So I'm hoping that over time we will get quite a large, with several thousand participants to be able to look at this in more detail. But I think the psychometric stuff would be very interesting.
So the item level data are potentially available?
Well, they are in our data, but we haven't got all that much data really. They're all trials, which, as you know, are painfully small and difficult to do. So, we've got sort of hundreds of people, but not thousands at the moment.
I think, yeah, okay. Well, I mean, a reasonable rash analysis could be done on about 250.
Okay.
Let's remember Glyn's an epidemiologist. Anything
Yeah.
10,000.
Yeah, anything less than 1 million doesn't.
Yeah. That's very good talk. Thank you very much.
Thanks.
I had a question, Glyn. So I really like this approach, partly because I suppose I have a more transdiagnostic way of thinking, and it seems the problem with transdiagnostic trials is what measures do you use to try and capture a very wide range of comorbidity or even primary difficulties. But I also like the fact that it's a sort of bivalent approach. And I'm wondering if the way you're validating it is therefore a bit conservative, say against depression scales. So the treatment resistant group are going to have lots of other problems. So when they think about feeling better, it's not just going to be their depression, but also looking at the traditional scales is removing bad stuff up to feeling an absence of bad stuff. But it doesn't really, those scales don't measure improving in terms of well-being or other things which we might associate. So in other words, feeling better is not just absence of bad things, it's presence of good things. And I like the fact that it captures that, but comparing it to the other scales, you haven't got that other dimension at all.
No, I agree. Yeah.
In the IAP data, which will.
Yeah, no, I agree completely. And in fact, we did, we published a paper which basically said if you look at improvement on the scales and compare them with people's own reports of improvement, there is a massive disagreement. I think there's about 50% of people disagree, or there's a 50% level of disagreement between saying you're better on the scale and actually showing some reasonable improvement on saying you're better on the global rating compared with the changes on the scales. And so, you're absolutely right. The scales, and indeed all the qualitative work, whenever you ask people, as we did, fill in these questionnaires, they say, this isn't really describing what's wrong with me, if you see what I mean. That they lack that sort of face validity in many cases. And indeed, when people talk about changes as well, they're saying, well, something nice happened, so I feel much better. And that sort of thing isn't really captured in these scales at all. They're just completely focused on symptoms and not all the other things which go on. So I completely agree. So it is a bit of an unfair comparison just to ask people to make a global judgment and then say, we've got these 9 depression questions, how do they perform? Not very well.
Yeah.
But I suppose, all the evidence we are looking at in clinical trials is that kind of evidence from these brief scales. And if we're going to use that clinically, we're going to have to make that judgment to the individual patient who will, clearly have all these other things in their head thinking, shall I take this or not? But at least I suppose you can say on average, should you take this medication, or what are the likely benefits for you? And maybe we can get to a point where we get more individualized prediction as well.
Another approach which I've seen, especially in say the youth trials like Bruce Chorpita's Match and stuff, is to look at top 3 problems in an idiographic way. Use that as your primary outcome variable. How much have your top 3 problems ameliorated?
Yeah.
What's your view of that kind of, I guess, more bespoke approach?
Well, yes, I suppose I'm never really, I've never seen a sort of trial analysed in that way, if you know what I mean.
So some of the Match trials, that's how they analyse the data.
Was it? Yeah, okay. Well, in principle, I suppose one of the problems with that is obviously, well, if people say, well, I've only got 2 problems, what do you do? Or if you've got, well, I suppose you've got 10, you've still got to pick the best 3 or top 3.
You add not enough problems as the third problem.
Yeah. Yeah, no, potentially that might be a way of doing it.
Okay.
I don't know whether you get it through a grant body at the moment as a primary outcome. The statisticians might worry about it. And I suppose you'd have to do some sort of psychometrics and reliability on it as well, wouldn't you? I don't know if that's been done.
Yeah, well, but again, only in youth trials.
Yeah, okay.
And it's because MATCH is a transdiagnostic intervention. So you can have any of like 15 diagnoses to be eligible for trial. And so they have to have something that cuts across. And I guess they're the same kind of principled argument that you're coming from, but just a different solution to it.
Yeah.
Okay, well, there's no more questions in the chat. So it just remains to say thank you so much for sharing your work, and it all seemed to go smoothly.
Thanks for inviting me.
Okay, thanks everyone.